I'll be introducing the speakers for the first plenary session that we'll be having in the updates of stroke care. Our first speaker will be Dr. Thomas Kent. He's a clinician scientist who leads a basic and clinical research program at Texas A&M Institute of Biosciences and Technology here in the Texas Medical Center. He also has a clinical appointment in vascular neurology at Houston Methodist. Dr. Kent has contributed many advances to the stroke diagnosis and treatment and is a longstanding member of the editorial board of Stroke and founding associate editor of several other stroke-related journals. Most recently, he founded a nanomedicine startup based on his and his colleagues' new technologies. This morning, he will update us on the recent discoveries related to stroke prevention and treatment. Please welcome Dr. Kent.
Okay, show me which one. That's one. Okay, great. Good morning. Thank you for braving the early morning and the sinkholes. So I'd like to update you on what's excited me about the last couple years in stroke care. First, a couple disclosures. Do have some intellectual property. Won't be talking about that. And I won't recommend any unapproved indications. So the focus this morning is on reperfusion injury. So reperfusion injury is the concept that injury to the brain is actually worsened after recanalization. This has been seen for decades in preclinical animal models and in cell culture, and it's probably related to the massive amount of oxygen that we're now restoring to ischemic tissue, but also probably glucose availability as well, and we'll talk about that. So to show this, it's pretty easy in an animal model. You just, with and without recanalization, if you actually get worse after recanalize, that's probably due to the recanalization. Often you get better, as we know clinically as well, but sometimes it gets worse. It's difficult to prove in a clinical setting, and some people don't think it exists, but often you see lesion growth, you see poor reperfusion despite the large vessel being recanalized. There's brain hemorrhage, which you wouldn't have seen if you potentially didn't recanalize, and then brain swelling. These are all considered markers of reperfusion injury. Lesion growth after endovascular therapy is more likely in the longer time windows. Doesn't mean it's not beneficial, but it seems to be seen more often then. So a couple recent articles have reviewed this literature. In this case, from Stroke, it's called clinically ineffective reperfusion. In other words, you successfully achieved reperfusion, recanalization, but you did not get recovery. And then speculating on why this happened. It could, of course, just be it was too late, the tissue was dead, but there's something called no reflow phenomenon where the small vessels become occluded, and we'll talk a little bit about that. This concept of reperfusion injury, timing, and other issues, and calling for more attention to this. When endovascular therapy started becoming more common about 5 years ago, colleague Midori Yanari published in Stroke a review of the potential, I don't know if the pointer works, mechanisms from a basic science level, and I won't talk much about this, that happens because of reperfusion. So ischemic brain sets in motion a number of different pathological processes. One of them is this thing called DAMPs, which is just a kind of a wastebasket for things that cells release when they're injured. And they bind to this thing called toll-like receptors 2 and 4, which activate the inflammatory processes. So microglia respond to that, and we'll get to that in just a second. But after you reperfuse, you have the potential to increase reactive oxygen species. Without oxygen, you can't have reactive oxygen species, so they're not there until you actually restore oxygen to the tissue. And then all these things we all know about, mitochondrial injury, blood-brain barrier damage for edema and hemorrhage, blood flow goes down, and eventually resulting in excess cell death. So there have been attempts clinically in the last couple of years to try to define this, and this is one study in Stroke a year and a half ago that defined reperfusion injury by an increase in lesion size from pre-endovascular therapy diffusion imaging. And they saw it about half the time, and then they correlated it, and it pretty clearly associated with worse outcome. Now again, establishing that's definitely due to the recanalization is virtually impossible clinically, but this is one way that it's been defined and at least being considered. So reperfusion injury isn't just increased cell death, but it's also injury to the vasculature. We sometimes forget that the vasculature becomes ischemic as well and starts setting in motion a lot of pathological processes, including the elaboration of adhesion molecules that start collecting platelets and white cells and blocking the potential for reperfusion. And we know that both thrombolysis and endovascular therapy increase the risk of hemorrhage and brain swelling. So one study that I was a little bit excited about that came out this year was the APTOL study. So APTOL study is from a company, AptoTargets, that developed something called aptamers. So aptamers are a new kind of a exciting potential therapeutic where you can screen thousands of different single-strand DNA molecules for their ability to block different kinds of receptors. And this specific one was to the toll-like receptor 4, which you'll remember is one of those initiating events. And what I like about this study, which was published a few months ago in JAMA Neurology, is they focused on a very specific patient population, which is endovascular therapy, less than 6 hours, with a specific aspect score. And I like this because it's probably a kind of treatment that's only going to benefit a certain population. And as we know, there's so many failures in neuroprotection, and one reason, and we and others have published on this, is when they finally get to the phase 3, they expand all the inclusion criteria, and so many disappointments happen because they're just wanted to increase their number of recruits rather than focusing on a specific population. So this did a safety study right before this and had a low dose and a higher dose of this particular drug. And it was a safety study, phase 1-2, so they looked at things we associate with reperfusion injury. Death, symptomatic hemorrhage, malignant stroke, and recurrent stroke was kind of thrown in there. And so these are their results. The pink is placebo, the dark red is the high dose, and the red is the low dose. And it had a pretty clear effect on reducing death from placebo. Now, I don't know if you consider 17% mortality rate high or low in this population, but seems about average. But, you know, it's a little concerning that the low dose seemed to actually increase death. Both intracranial hemorrhage and malignant stroke were reduced by the higher dose, and that's encouraging. And then this slight increase in what this thing called recurrent stroke. So, of course, the authors considered this very positive. I think it's mixed. You still have to look. It's a little bit concerning when a low dose might actually worsen things, because then when you get to a larger population, some people might metabolize it differently. But anyway, I think it does warrant a phase 3, and we'll just keep a lookout and see what happens. So what is the biggest risk factors for reperfusion injury? Well, one is time. The other is the extent of the initial injury. But it turns out that high blood sugar, when a patient appears at the hospital, is the #1 independent risk factor for worsening edema, hemorrhage, and mortality. And, you know, we've known this for decades and reported it. And an interesting finding, even early on, is that it seems to be actually worse if you have hyperglycemia and you're not diabetic. It especially occurs when you reverse the ischemia, either with thrombolysis or endovascular therapy, and virtually every study shows this as an independent risk factor. Well, why glucose? So glucose is a real bad oxidant. It auto-oxidizes, it can oxidize things around it. We know about the advanced glycation end products, that's what hemoglobin A1C is, and itself is a damaging molecule. But it also sets in motion, just because of the way it's handled and the molecular events that the way we transport glucose, a lot of different things, all of which end up resulting in a really bad vasculature. They become vasoconstricted, they become thrombus prone, and also become injured to the extent that they may promote hemorrhage. Who's at most risk for hyperglycemia during a stroke when they come and present? Well, when glucose goes over and above an individual's usual glucose at the time of illness or stress, we call that stress hyperglycemia. It can occur in anyone, but it especially occurs in diabetics, pre-diabetics, and other risk factors common, like a high BMI, sedentary lifestyle. So stress hyperglycemia, in this recent review in a very good journal, Scientific Reports, suggests that it is a factor related to both prediabetes and type 2 diabetes. And in fact, the amount of stress hyperglycemia linearly predicts the chances of getting diabetes over the next few years. So it's a really important target. And it worsens outcome. In this recent review where they looked at different studies looking at stress hyperglycemia, they've divided it by quartiles. It's defined by the ratio of your glucose level to your hemoglobin A1C. And anything above 1 seems to reflect a stress-related event. So the higher quartiles, there are a few things that related to a better or worse outcome, but you can see how consistently the higher the stress hyperglycemia ratio, the more chances of a poor outcome. And then another study in 22 looked at whether this is worse in diabetics or non-diabetics, and they defined fetal recanalization as full recanalization but no clinical outcome, and then also looked at mortality. And this was tertiles, and if you looked at the worst ratio, they had an incredibly worse chance of a good outcome, in the 16% in the non-diabetics, but barely above what you'd expect and not significant in the diabetics. So it really is an important factor. So if we had increased attention to stress hyperglycemia, this might lead to an increased attention to the risk of prediabetes, and this may have a profound effect on their future stroke outcomes. And this is the thing that I'm most excited about the recent developments, and that's the glucagon-like peptide-1 agonists that are now being shown to reduce all vascular events, including stroke. So what are these? These are incretins that are secreted in the industrial epithelium. The drugs are therapeutic mimics of the naturally occurring GLP-1, and they're receptors not just on the pancreas and in the GI tract, but in the heart and the brain, and they affect their function. What it does is increase the ability to secrete insulin in response to glucose. It inhibits glucagon, which you may remember is the main hyperglycemic hormone, and increases insulin sensitivity not just in the pancreas, but also in neurons. CCK neurons in the brainstem, which are responsible for appetite, may also explain the weight loss and nausea that comes from these drugs. And they have an incredible effect on stroke reduction. All the ones that have been studied for vascular events, a range of 15 to 29% reduction in all forms of stroke. Reduces hemoglobin A1C, and it's a profound effect. Every 1% reduction in hemoglobin A1C is a 41% reduction in stroke risk. And reduces blood pressure, affects renal and blood vessels. And it reduces the incidence of atrial fibrillation, probably by effects on the way cardiac cells remodel. And more, in the recent years, there's been increased attention that it's really atrial fibrosis that results in the stroke risk from atrial fibrillation. So this may be another way that all forms of stroke are reduced by some of these drugs. Affects lipid metabolism, affects the endothelial cells as well. And now it's being used for weight loss, so it's not just an indication for type 2 diabetes. And a recent review on that concluded that when you use these drugs for weight loss, that you might improve glucose metabolism, blood pressure, and body weight, and it could prevent the development of diabetes and reverse abnormal glucose metabolism. So what did that show? These are forest plots. In this case, to the left is weight reduction. All the trials reviewed reduced weight, reduced systolic blood pressure, reduced BMI, a little bit of blood pressure, and waist circumference. But what did they do to glucose? These are odds ratios, anywhere from 3 to 6-fold reduction in hemoglobin A1C from pre-diabetes levels to normal levels. 2 out of 3 trials showed that it reduced the chances of developing diabetes. It reduced postprandial glucose and a little bit in your average glucose levels. So a recent paper, I think a really important paper that I'm going to conclude with in stroke in 2022 is a call to action to neurologists to become more aware of the effects of the GLP-1 receptor agonists on stroke reduction. Now, they made a case that it may actually be neuroprotective, and scrutinizing those studies, I think as a basic scientist, maybe, maybe not, and maybe if it does, it might be because it's reducing stress hyperglycemia. They didn't consider that as one of the options. But we talked about the direct effects that all are favorable in terms of reducing atherosclerosis and their indirect effects on blood pressure, weight, and hemoglobin A1C. What this study paper review includes is also at the end resources for neurologists considering using these drugs for their patients, with frequently asked questions and answers that you might want to have if you're going to start these medicines, and a decision algorithm. I'll just show you an example, what kind you can expect in this paper, which studies show what kind of metabolic effects, which ones reduce stroke risk, how to begin it, what are the side effects, what are the contraindications, et cetera, et cetera. And then a nice algorithm, if you like algorithms and can follow them. I have difficulty sometimes with that, but whether you're diabetic, what drugs you're on, et cetera, and how to use a drug. So I definitely recommend that you Google that, call of action for neurologists and stroke, and you'll find this article. So I will stop there. Thank you for your attention, and I guess we'll have questions later.